And it's interesting because I think, again, going back to this issue of fragmentation, what we're seeing is that, a lot of the same concepts keep reoccurring. And what I think is most important to the thinkers, whether they're right or wrong, but most important to the thinkers in the federal government is that we start having things that are multi-payer sponsored. Because to the extent that you're redesigning here one way and here another way, it's very, very difficult to actually, get traction. When you talk to Lee Sachs, who obviously has done a lot of this clinical integration, the big thing that I think he talks about is that the metrics are all the same. He worked very hard to get the metrics for all payers into, one sort of managed care contract that worked across the system for doctors. So anyway, let's quickly go into a little deeper on what ACOs look like or could look like. And again, the core principle here is accountable care as opposed to irresponsible care, aligning payments, benefits, and other health care policies with measurable goals. And this is all in the guise of trying to lower costs while improving quality. So, for me, one of the things that I say when people say how to start, I would start, if I were a hospital CEO, maybe with a community needs assessment. You do that anyway, and looking through where you've got gaps in your community, what you do well, what you don't do well. That to me seems, that inventory of services, quality and cost, seems to me to be the starting point for anyone. And pulling out or getting online and seeing Dartmouth Atlas and saying, okay, in our county, if Joliet is, I'm sorry, I said it wrong earlier, it's 10,004. If Milwaukee is 8,059, La Crosse is 6,008, and Wausau, Wisconsin is 7,894. Where are we? And where do we think we can and should be? That would be my initial. Then the second thing I would say is, whether you're dealing in the Medicare ACO or the commercial ACO world, what you kind of have to visualize is how is the accountable care organization, how might it work, and who needs to be at the table. The Congressional Research Service notes that the current system pays for units and holds no one responsible. The ACO is the opposite of that. We're going to try to pay for, we're going to assign a budget, and we're going to try to hold people responsible for that. So how do you get people into one organization structure? That's a key thing. How are you going to develop systems? And these systems might be simplistic at first to coordinate care so that you've got an opportunity to improve quality. What are the small steps that you can take? Are you going to hire an administrator who's going to, and are you going to establish a formal legal structure? Now, and I don't want to put the law above the practical, but I think in this context, determining who you need around the table after you do this community needs assessment and actually getting those providers in dialogue, in relationship, and potentially thinking through how you might put together an organizational structure. And again, I don't think it has to be I would not put it as a primary focus, but I would put it as maybe something you're doing in addition to other tactics. Because I think once you get people in that organizational structure, they're going to be less likely to abandon you and go with a different ACO if you're not moving fast enough. And you've got people around the table and they're working towards a goal. And I think that makes people more comfortable in this environment. So maybe that's the role for the organizational structure at this juncture. The other thing you're going to have to do pretty quickly is figure out financial bonuses. How are you going to pay for this? The capital investment to fund the effort. I think a lot of times the reason that doctors think it's really good to have health systems as the centerpiece of an ACO is because they have the capital and the IT. That's really, as opposed to joining forces with the provider, the hospital is a more familiar entity, and you have the capital to fund this. Now that may or may not be true depending on unique situations and the willingness of senior leadership to pay for redesign. But that's the idea. That's why physicians will come to the table. So if you're not going to pay for it, and some health systems are saying, well, we really don't want to pay for this whole thing. Well, who is? Are you going to get grants? Are you going to get money from the federal or state government? Are you going to get money from insurers? And later, John Foley will be on the panel. But some redesign, progressive health insurers will pay for. They might not pay in the amounts or the levels that you think you need for payment redesign, but having some of those some of those, having the health insurers at the table, if that's consistent with the culture of your community, might help fund some of that. You have to determine how you're going to look at what efforts you're going to put in place and how you're going to develop financial incentives. And I think it's really important that you think of financial incentives two ways. One is at the global level. What kind of financial incentives are you going to create for yourself vis-a-vis a payer? And then secondly, what kind of financial incentives are you going to create among payers to produce a coordinated result? So that's really the two levels of inquiry. And I tried to make it sort of a simple explanation of how to get started, because I think those concepts are the incubator for this ACO. What is the shared savings program, the Medicare ACO? What does that require? It requires these 6 items. And again, my thinking is you might not be doing this to become a participant in the shared savings program, but you're doing this because you have other business needs. This fulfills other business needs, and then at least you have the option when the regs come out, as this thing unfolds, to be ready to be a part of the shared savings program. What we know right now is that these 6 things are going to be required: define processes to promote quality care, report costs and coordinate care, develop a management and leadership structure for decision making, develop, again, formal legal structure that allows you to receive and distribute bonuses, have PCPs, 5,000 Medicare beneficiaries, and contracts in place with specialists. And I would add to number 5, other providers, whether that's subacute rehab or hospice or long-term care, and be able to have 3 years worth of participation. So whether you decide to participate or not, that's what's required. Very little guidance. We're hoping for more in the regulations. How could you set up your ACO? And again, Ron Williams' quote, we view it as, an industry sees ACOs as sort of the incubator, and so a lot of things are in the ACO, whether that's partial capitation, medical home, bundled payments, healthcare information technology, all kind of becomes part of your movement. And this organizational structure, why not use it for some of that as well, and some of that progress that you have to make in these particular areas. We came up with sort of, and again, in an effort, and we value simplicity, we came up with 3 sort of models. And we thought these are not rocket science, but these are models where you could say, yep, I understand it, this is how I could put in place. So if we claim for the health system the role as the integrator, the local health system, then how do you envision the structure unfolding? And in our mind, there's sort of 3 basic structures. You could have a structure that's aligned but not controlled, with the ACO be a separate corporation that's friendly and complementary to the health system but stands alone, and it's the health system and others. You'd have to define who the others are. Community board potentially, opportunity for partnership with physicians and insurers, maybe even employer alignment depending on how the payers are in your community. But this board up here, in my mind, in this model, is a broad cross-section of the community coming together around population health and with an attitude towards innovation. I envision this model as a nonprofit design where payments are, payments come into an ACO, but are not, there's not an effort for profit at the ACO level. There's an effort for conversation and planning and design, and then providers are paid down here. Not through dividends or return on investment. So that's why I envision this as a nonprofit primarily. Again, with no shareholders here, no obvious source of capital for redesign. And that's something I think that's a critical question. How much do you need to redesign in terms of healthcare information technology, and how much do you need in terms of other work you have to do? This is another potential design option, and there we have a wholly owned subsidiary. Assuming a nonprofit health system, this is probably a nonprofit corporation that's a subsidiary. This is a very health system-driven model. We've got, we're asking basically the rest of the world to come under our umbrella and be part of our ACO development, and we're keeping a tight control on it. One of the questions that is out there from a legal perspective is 501c3 status. if you have an independent corporation, may not be eligible for 501c3 status. As a member of a health system, likely through as a supporting organization, you're going to get 501c3 status. May not need 501c3 status, but if that is desired, that this is the sort of the surefire, easy bet. I'm not sure that it creates sort of the right paradigm for total community involvement, but it keeps the ACO close to the hospital system and its governance. The last design possibility, option 3, is sort of a joint venture format, and it involves the health system owning a part of this ACO, other providers, other venturers owning some of it. It could be nonprofit. You could make it a membership corporation with reserve powers, or it could just be a for-profit entity where you have an LLC or you have a stock corporation and people actually put money in. This envisions sort of capital coming from different groups and a decision made as to who's putting in what money to fund redesign, and then having potentially physician groups as owners in this new entity. Probably from a tax-exempt status, if you've got a tax-exempt health system, you're going to have some pretty significant reserve powers there. But you can set this up as a for-profit, and then there would be possibility for distribution of profits if they were made at the ACO level to members. Again, insurers could be part of the equation. I like this because I think if people put capital in, they're more invested. And so it launches, this from a health system standpoint, launches the organization, provides capital, but also provides a mechanism for control of some of the major issues that affect the entity in terms of reserve powers or supermajority rights. So again, those are the 3 that I think are obvious. There may be other variations on those. But again, you got to think about, what are you trying to do with this organization? You want to have contracts with Medicare. You want to have contracts with payers. You want to launch redesign. You want to have IT rolled out. What is your functionality? Then who do you need at the table? And how do you get all those people enlisted? And who's going to pay for it? So this is the bundle of legal obstacles. And in light of time, I'm not going to go through all of them. I'm going to just say I think that each one poses it probably could be a 2-hour speech, poses its own challenges. I'll just say I think each one of them can be dealt with and can be handled, and we know how to do it. So our ACO is the missing piece. Go ahead, Kevin. Well, I think one of the real... There is a side paper that we're writing on, waiver options, because I think that's essentially what you're talking about, Kevin. And I think there are 3 out there. There's, sort of the status quo with creation of safe harbors, so that you could kind of know what the ACO needs to look like. There's option 2, which is a creation of a process for ACO waivers on a case-by-case basis that should be sort of expedited. There's also sort of a issue, sort of a blanket waiver for certain laws that are affecting design that's been talked about. We don't know. We don't know which one. I've read various articles in terms of the different waiver possibilities. That has to be addressed. Interesting, though, I'll just take antitrust, because everybody talks about antitrust and clinical integration, and I can do a little bit of a deep dive on that and just say, when you're, what I've heard regulators talk about that, and they'll say, hey, what you're worried about in the whole antitrust. Let's see if I go back. The antitrust world is you're mainly worried about price fixing. That's your big issue. When you're an IDS and you have all employed doctors, you're one entity, you don't have price fixing. Everywhere else, you've got to be concerned about it. But then they say, remember, if Medicare sets the price, there's no worry on price fixing. So if again, functionality, if your ACO is set up to be in the Medicare pilot, we're not going to do a lot of work on the antitrust piece. Now, when you go out to other payers, yes, we have to be concerned. Remember, there's existing antitrust advice on how you avoid a price fixing problem. 2 ways to do it: clinical integration, which was the advocate model, or financial integration, which is risk sharing. You don't need to be clinically integrated to be outside, to have a legitimate joint venture where there's risk sharing and you're distributing it. And part of your financial incentives creates the financial risk sharing, which takes you out of a price fixing issue. So when I think it's up to the business people to design the functionality and say, what can we accomplish and what do we need to accomplish? And then that antitrust piece fits into that. But when the regulators stand up, they say we have lots of guidance out there. We don't have to do a safe harbor. So that's kind of that's the kind of tension right now. And to me, even under the Stark law, there is some proposed regulation out there that sort of gives us some guidance, and you can go into with both anti-kickback and Stark into some of the gain sharing pronouncements, and you can get comfortable. If you're per capita, you're not rewarding referrals, your fair market value, you're set in advance, you have a formula, you're going to be okay. I don't think you're going to be the big sore thumb that the regulators are going to say. Okay, this local hospital that went out and got all the stakeholders involved in an effort to improve health care. They designed a formula. They made sure they had a fair market value opinion. They made sure they weren't rewarding referrals. But we're gonna throw the Stark law at them. And I don't see that. And again, I'm a little less. There are attorneys that are a little more conservative, a little more aggressive. I'm a little more aggressive on that. But I believe you can today with what we've got out there, design around it. So I better turn it over to Chris. Chris is going to talk about IT and value-based purchasing, and I know you're going to want to hear from him.